Hello and welcome to the Oath and Staff podcast. I am A. David Singh, bringing you stories from people of medicine who serve humans and animals in unique and wonderful ways. In today's show, we are talking to neurosurgeon Dr. Iype Cherian. It was a cold, wintry morning in the year 2000 when I met Iype for the first time. We had assembled for the neurosurgery entrance exam at CMC Vellore in South India. The two of us trained at Vellore and became neurosurgeons. 7 years later, I left neurosurgery to become a historical fiction and fantasy author, and now a medical podcaster. However, I pursued neurosurgery with a passion, carving an illustrious career that has helped countless patients and inspired a new generation of young neurosurgeons. Welcome, Iype. Welcome to Oath and Staff.
Hello, David. Good to see you after such a long time, buddy.
Let's kick things off at the beginning. What got you started in medicine and later in neurosurgery? Is there a story behind why you decided to become a neurosurgeon?
Well, when I started off, I was more interested in physics than anything else. So I would have naturally become an engineer. But then I was left handed and I was writing in a very vague way. I had to lie down and write with my left hand. So the family decided to get me back to right hand. And, as stubborn as I was, it was impossible for them to do it. So they had to resort to having a plaster on my left hand. So when I started writing with my right hand, I was mirroring everything. So it took me some time to get back. One of my teachers really helped me to do that. I realized that I could write with both my hands. When my dad's uncle, Dr. Matai, saw this, he told me that if you did neurosurgery, you would have a very unfair advantage being ambidextrous, truly ambidextrous. So that's my only reason I would take up neurosurgery. I'm probably the only doctor in a family of engineers.
After your initial training in South India, which countries has neurosurgery taken you to?
Well, I finished training from Vellore and I went to Japan, as you did, for a couple of years. I was in Nagoya with Professor Kato and Professor Sano, where I completed my vascular fellowship. That was in 2009. And from 2012, I have been a faculty to the World Federation of Neurological Surgeons in various capacities. And also, I've been the general counselor for Asian Congress of Neurological Surgeons. So that has taken me to over 40 countries as part of giving lectures on my inventions and my other neurosurgical tools.
Since you've worked and traveled as a visiting neurosurgeon in several countries, did you come across language barriers and cultural differences? How did you adjust to those experiences? Is there a funny story that you can tell our listeners and viewers?
There were a few countries where English is not very commonly spoken. The first problem that I had was in Japan. So every time we would try to go and get something in Japan, it was a struggle. So to get an egg, we had to literally draw a hen and draw an egg next to the hen. And the same way, I've had problems in China. While the cities, we did not have much of a problem. But in the interiors of China, we really used to have problems trying to communicate even with the neurosurgeons. And especially in the theaters where if we wanted a scissors or if you wanted a suture, we couldn't really communicate better. So somebody had to stay with us. South America, it was mostly Spanish and there was always people to help us around while surgeries and while doing lectures.
Well, I can completely relate to that. And my story about Japan is very similar to yours about drawing a hen and egg. In fact, in one of the earlier podcast episodes, I had recounted that story. So I completely agree with you. Going to different cultures and different countries, it is an eye opener because we feel that knowing English can take us all over the planet And that's not really the case all the time. So, after your initial adventures in neurosurgery, you went on to subspecialize in skull base and vascular neurosurgery. And that in turn led you to develop and popularize a surgical technique called cisternostomy. But before we talk about cisternostomy, tell us what a typical work day looks like for you.
For the last 10 years, I operate only 4 cases in a week. I have a team. Right now I have 3 professors with me, junior consultants, postgraduates, fellows. So I select a, a few cases in the week. This may be mostly complex aneurysms or anastomosis. These are what I like. So mostly brain stems, petroclivals, anastomosis or complex posterior circulation aneurysms. These are what I would do. Then I have my innovations meetings and I have meetings with companies. So that's what my typical day would consist of.
And that leads us to something that I'm very eager to hear about, a technique, a surgical technique called cisternostomy. In simple terms, could you tell us what is cisternostomy and what is the story behind how cisternostomy found you?
I was working in Alleppey way back in 2007. I had gone for my first fellowship in Japan and I had come back. So I wanted to do all the aneurysms. On one Saturday, I had these 2 cases. One was trauma and one was an aneurysm. So since it was a Saturday, I asked my junior to prepare the aneurysm first and then go on with the trauma. So we did not have the smartphones of these era. We had the alphanumeric phones at that time. I remember that the ambulance came with the angio to the shopping mall that I was in. And I saw the angio film. It was a simple looking aneurysm. He told me the brain's a bit tight. 1 hour later, I went in and he's done the craniotomy. So I started, when the brain is tight, we start opening the cisterns to get the brain lax. That's what is done in every aneurysm surgery. So I did the same thing. And then I started dissecting, looking for the aneurysm. For almost an hour, I dissected the entire anterior cerebral tree, including the 2A1s, the communicating segment, but I really couldn't find the aneurysm. At this point, I asked my assistant, I can't find the aneurysm. So then he said, there is no aneurysm because this is a trauma. This was something that happened because both of us had not communicated. I noticed immediately that brain had become so lax. And just like in an aneurysm, the trauma brain, which was very tight to start with, had become really lax. The teaching for the last 4 generations is that we should not keep the bone flat back. So we did not keep the bone flat back. We closed, and the next day, what we found was that the patient was already pulling at the tube. So we had to extubate him. So this was a result that completely changed my outlook about trauma, because the scan wise, this would have been a patient, we would do a decompressive, the brain would swell and the patient would be on the ventilator for almost 20 days. And then he would go to rehab like a vegetable. We had been in Vellore, we had seen this so many times, and this completely changed my outlook.
The most wonderful discoveries, life changing discoveries, are due to serendipity. And this is a wonderful example of that. Thank you for sharing this tale. I was not aware of this particular adventure of yours. Can you briefly talk about the underlying mechanisms and how system aneurysm is beneficial to patients with brain trauma?
When we were doing cisternostomy for almost 5 years, we were not really understanding the mechanism. Why would cisternostomy work? We didn't know. Then I started looking at the anatomy and physiology of the brain in much more detail. And I realized that the cisterns at the base of the brain, they have about 120 ml of CSF. And we were all thinking that this was to just suspend the brain. This is what most of the people even today think. But this CSF was getting changed 3 times a day. So why would the CSF get changed 3 times a day if it was just to suspend the brain? I started thinking that this CSF must be doing some cleaning or doing something other than what it is meant to, as per our understanding. Can the CSF go into the brain? Is there a channel for the CSF to go into the brain? You see, all the vessels are going into the brain from the cisterns. Anterior perforated substance, posterior perforated substance, the circle of Willis, everything is in the cisterns. All the vessels are literally in the cisterns. So we started looking at the Virchow-Robin spaces, and we found that these are potential spaces for the CSF to go in. Now, how does the CSF go in? We looked at the Archimedes screw mechanism, where you put a screw into the river with a tube around the screw, and you turn the screw, the water comes in. That's what Archimedes did to take out water from the rivers. The screw, if you look at it, is a wave. When you turn the screw, actually you are advancing the wave. So where is the wave in the cisterns? The wave is the pulsatility of the vessels. So if you have a pulsating vessel and you have a space around it, the Archimedes screw principle will drive the CSF from the cisterns into the brain. From 2009, we were talking about this, about the CSF shift through the Virchow-Robin spaces. But unfortunately, there were no publications at all. There was no basic science to support our view. By 2012, when the G lymphatic system came in, people immediately embraced this idea. And we figured out that CSF was going into the brain. Now, how does that help in trauma? You see, the cisterns are full of CSF generally, but when there is a trauma, the first thing that happens is subarachnoid hemorrhage from the capillary bleeds. So the blood is a newcomer into the cistern, and the blood comes into the cistern at very high pressures, almost 50 to 60. The cisterns start filling up with blood. And when the cisterns start filling up with blood, the water, the CSF, has to shift. And where can the CSF shift? The CSF will only shift into the Virchow-Robin spaces. So the entire 120 ml of CSF shifts into the Virchow-Robin spaces. It's just like injecting a 1.5 liter Coke bottle. Inject 120 ml into that Coke bottle. See how much the pressures go up. That's exactly what is happening to your brain. And that's why when you do a decompressive, the brain just comes out. The natural answer to this would be to open the cisterns and allow the cisterns to be into the atmospheric pressure. That's exactly what we should do instead of opening the top and allowing the edematous brain to just come out. That's the mechanism of how cisternostomy works.
You have talked at length about brain cooling, unlocking of the skull base in relation to cisternostomy. Could you introduce these terms to us?
Yeah, so after we figured out how the brain is literally irrigated by the CSF and the cleaning takes place through the CSF, we also looked at how the brain is cooled. And this was so interesting because you look at all the sinuses, the frontal sinus, the ethmoids, you have the maxillary sinus, you have the sphenoid sinus. All these sinuses, they're like a concave mirror. And at the isocenter of this concave mirror is the largest collection of your CSF. These sinuses, they're like a room filled with a wet cloth. And it's also special that they have a very small opening. And when you breathe, because of this small opening, there's a jet of air going into each of these sinuses. And this jet of air evaporates the mucosa that is in the sinuses. The sinus becomes almost 4.5 degrees cooler. All these sinuses cool 4.5 degrees, and by convection, it is cooling the suprasellar system. And that cooled CSF from the suprasellar system is pumped into the entire brain by the pulsatility of the vessels. So imagine what a beautiful system. You have a radiator and a radiator fan, and you have something that pumps the entire cooled CSF into the brain. So we described this. People thought it was crazy at first. But then I was talking about this in Paris, and Ian Opris, who was bringing out his Springer Nature textbook, he told me he wants as the last chapter. So we wrote it up, and now we have so many citations, and the implications are every neurodegenerative disease from the lenticular striate territory like the Parkinson's, Lewy body diseases, to the convexity like Alzheimer's and amyloid angiopathy. Everything is being related to the cooling and cleaning abnormalities.
Wow, that's wonderful. There are so many things that I'm learning today that I was not aware of when we were in training. You have also talked at length about the importance of sleep and how it cleans the CSF. Could you just give us a brief summary about that?
The cooling happens all the time. It's 24 hours. But unfortunately, the cleaning doesn't happen the full time. The cleaning can happen only when the aquaporin 4 channels are open. And from the Virchow-Robin spaces, the CSF, through the aquaporin 4 channels, the CSF gets into the cell cytoplasm or the ISF. So when the CSF communicates with the ISF, it cleans out all the metabolic wastes like chloride, ammonia, and many more. And this can happen only when you're sleeping, especially in the left lateral position.
As you know, our neurosurgery training ingrained excellence in patient care and surgical skills through everyday experiences. But that excellence came at a cost. There was a dark side of our training that forced us to keep our switches on day and night. There was no concept of rest or being off during weekends or even being off when we were not on call. Timely meals or a good night's sleep was unheard of. I was never sure when or if I would get sleep at night. To a large extent, the lack of sleep transformed me into a warped human machine hybrid like the Borg. Ipe, have you seen the famous sci fi TV show Star Trek The Next Generation? Do you know who the Borg are?
I've seen Star Trek, but I'm not aware of who the Borg are.
Well, the Borg were a peculiar and remarkable species. They had machine parts embedded into their bodies and cables running in and out of their skulls and chest. Captain Picard of the Starship Enterprise and his crew had many adventures with the Borg. Even though the Borg were technologically superior to humans, they talked and walked like zombies. I believe we had become like the Borg because of sleep deprivation. I remember walking around the hospital in a haze for the 6 long years of our training. Of course, that caused a sharp decline in my personality and dehumanized me. Sometimes I think about those days and wonder, is there a balance? Is there a fine line? Ipe, let's imagine a scenario in which you are the program director responsible for neurosurgery trainings. How will you design a balanced approach in your training program so that the surgeons of tomorrow acquire academic, clinical, and surgical excellence without it taking a toll on their mental health?
So that's a very difficult question, very interesting question. Now, there are many faults with the present training program. And what I thought was that we had too much documentation, which we can really avoid. Sleep deprivation, as you said, is definitely not on the cards for a training program. And other than that, What I feel is surgical skill training, which was very less during our times, mental fitness training and mental fitness screening. This was not important. So there are some people who are artists, there are some people who are speakers. The same way, there are some people, who are fit for surgery. I mean, it's not that they're superior, they just fit into surgery better than others. We see a lot of examples where people who are truly brilliant, they come into surgery and then they don't fit into surgery. So if I was a program director, I would screen people and probably advise them, maybe this is not the best thing for you. As a surgeon, you don't need much intelligence. In fact, what you need is you need to be able to take stress every day in and out and then be able to survive in that stress. And also, I will probably train people more in anatomy. We have an Esculap Academy lab, so we would. I'm doing that right now with my present system.
I thank you for sharing your thoughts. It was not a question that everyone has an answer to. And at this juncture, I would also request our listeners and viewers who have teaching responsibilities at their hospitals to dwell upon this issue and help to create a balanced approach in their surgical and medical training programs. Through the Oath and Staff podcast, I hope to make you ponder and also entertain you. So, in addition to highlighting issues in medical practice, this podcast focuses heavily on storytelling and learning from those stories. That's how I process the world around me, through stories. Today's story is about Ignaz Semmelweis. In the 1840s, it was widely believed that human disease was caused by bad smells in the air that rose from rotting corpses and sewage. Ignaz Semmelweis, a Hungarian doctor working in Vienna, noticed that there was an alarming prevalence of fever called childbed fever that led to death in women giving birth. In Vienna, there were two maternity clinics, one led by doctors, the other led by midwives. Surprisingly, the doctor led clinic had a much higher rate of childbed fever and death than the clinic run by midwives. Semmelweis wondered why childbed fever and death were so common with his doctors. What were they doing wrong? He began examining the differences between the two clinics but could not solve this puzzle. Why were deaths more common when doctors did the deliveries versus when midwives did them? The solution found Semmelweis in the form of a personal tragedy. One of his doctor friends was accidentally cut by a scalpel while doing an autopsy in the morgue, and he died of the same symptoms as the mothers who suffered from childbed fever. At that time, the medical community did not know that germs like bacteria and viruses caused diseases in humans. So Semmelweis came to the conclusion that his doctors were picking up particles from corpses in the morgue and transmitting them to the women during childbirth. That seemed plausible because midwives did not do autopsies and hence had no contact with corpses. To test his hypothesis, he ordered his doctors to wash their hands in chlorinated lime between autopsy work and examining patients. To his surprise and delight, the rate of maternal death in the doctor led clinic fell from about 18% to 1% over 4 months. Excited with this breakthrough, Semmelweis shared his hand washing technique with the medical fraternity, but he was met with stiff resistance. His peers were adamant that human disease was caused by bad smells in the air. They rejected his hypothesis, many even ridiculed him. In the end, he was unable to convince them to adopt hand hygiene. It was a few decades later, through the works of Louis Pasteur and Robert Koch, that germs like bacteria and viruses were recognized as the cause of many human diseases. And that brings me to my next question. Ipe, Through your numerous talks in conferences, hand on workshops for young neurosurgeons, your YouTube channel, and your recent textbook, A Practical Manual for Cisternostomy, you've had a measure of success in convincing the neurosurgical community about the efficacy of cisternostomy for brain injury. However, let's go back in time. Was your initial experience with talking about cisternostomy and spreading the word met with resistance like Ignaz Semmelweis? Walk us through some of the challenges you faced and how you overcame them.
Any change brings resistance and ridicule. I realized way back in 2008 and 2009, I thought cystonostomy would be a given. People would just change, and I might probably get a Nobel Prize in a couple of years because this was so significant. But when I went to conferences, people were laughing at me. When I drew these line diagrams of how CSF shifted into Varsha Robin spaces, they were laughing. And so I was the court joker, the court jester for many conferences. Here comes the guy who's going to entertain us. So, from an entertainer over the years, I made them doubt because once the G lymphatic system came, I made people doubt. And then there were a few people who came to my center and they saw what I was doing. They were critics, but they came and saw. And later on, Dr. Guo Yi from China, Dr. Wang from China, Dr. Parthiban, all these guys, they came and saw what we were doing and they saw the results and they were amazed. And they started things on their own. And one of the things I realized, there was a big mistake that I was doing. I was complicating everything. This was my innate habit. I was doing a cystonostomy by doing an anterior clinoidectomy, cavernous peeling, sometimes posterior clinoidectomy. And this was not needed. So later on, what these guys did was they simplified cystonostomy. They said, you don't need to do all this. You just need to drill the sphenoid ridge and get into the cistern. Probably because I was making things very complex. That would have been a reason why I was laughed at because nobody would want to get into the theater at 2 a.m. and, drill the posterior clinoid between the carotid and the optic nerve. So I had a lot of resistance. And right now, I would say we are much more accepted than before. Now we have this cystonostomy in the Geno study. The last World Neurotrauma meeting had a workshop, and the workshop was on cystonostomy. So we've had workshops in South America, in Europe, in almost all parts of the world. So this way, things have improved. But as you said, the initial few years was ridicule, resistance, and a lot of critique from my peers.
Well, we wish you all the very best to continue spreading the word about cystonostomy, convincing the neurosurgical community about it. Slowly, people will start changing their opinion, and cystonostomy might become the standard of care for traumatic brain injury. At the time of recording this podcast, you are about to start a new position at Bangalore in South India. Congratulations, and we wish you all the very best.
Thank you.
In the past, you've had the distinction of starting two neurosurgical departments and developing both into centers of excellence. What's more remarkable is that both these departments were in the neighboring country of Nepal. How did the universe present this unique opportunity to you? Tell us the origin story of what you call neurosurgery in the Himalayas.
Well, my uh, dad's uncle, Dr. Matai, was a very influential mentor for me. So after my stint in Alleppey, I wanted to go to a place which was quiet, and what we found was Christchurch in New Zealand. They had a department, so I was all set to go there. And a week before I was going there, Dr. Matai asked me whether I would like to spend some time in Nepal helping out one of his students in Kathmandu. Nepal already had a kind of mystique, so I thought, let's go. And that's how I went to Nepal. But what happened? One of my patients for whom I had done the cisternostomy, he took us to a place called Pokhara. And when I went to Pokhara, we found out that there was a Manipal run medical college. So I wanted to visit the Indian run hospital, and I found it to be a beautiful hospital. The CEO was Brigadier Nagpal. He told me that they would very much like to start a department of neurosurgery. I was not very convinced. I mean, it was a small city in Nepal, so I was not very convinced. I was going back. But when I saw there was a young man carrying an old man in a basket suspended on his head. So this asked this man, he was understanding a little bit of Hindi, and I had a few guys who could translate. I came to realize that this young man had walked for 2 days with this old father in his basket, and this old man had a spinal cord injury. And then I realized maybe this is a place that I can make a difference. So I immediately went back to Nagpal and I told him that I would start the department there. In 2008, I started the department in Pokhara, and I was there for 2 years. Today, there's a big department. My students started managing it, and one of my surgery PGs later on became a professor of neurosurgery. I believe they are getting the PG programs as well. So that's how we started off. And then I went to Central Nepal, Chitwan, stayed for 8 years, started the department, started the residency program. Then I went to Eastern Nepal and stayed there for 4 years. So a total of 14 years I stayed in Nepal, started 3 centers from east to west. When I came, there were only 7 neurosurgeons in Nepal. By the time I left, there were more than 100. So I would say I've done my part.
That's a tremendous achievement type. I was aware of 2 centers, but now I realize that there were three. What I did not know was the number of neurosurgeons that you had trained. That is really incredible. A tremendous service to the people of Nepal. Thank you for that. I have watched some of your YouTube videos in which you talk at the intersection of brain science, mathematics, astronomy, and spirituality. That's fascinating for me. Will you give our listeners and viewers a glimpse into that facet of your life?
Well, in Nepal, I I had visited many places, especially Muktinath, and these were high in the mountains, and this gave me a lot of time to reflect. And I started getting interested in the concept of Shiva. For me, this concept was very interesting because I had a big liking to quantum physics. I read the book Tao of Physics by Fritjof Capra, and I started writing to him. I started realizing that the East and West are not really so different. The East had faith, while the West had evidence. In Shaivite Hinduism, what they say is when you have faith, you are nirakar, or you have no shape and you're free. And when you look for evidence, you become akar, or you start to become something with a shape, and you start becoming confined to space time. So this is something that really interested me. And if you look at the double slit experiment, the photon experiment, what they did was they had two slits and they sent a photon shower through both. And they thought the photons would behave like particles and create two patterns on the wall. But what they were surprised to see that there was an interference pattern, which was typical of the photon being a wave. The moment they started to observe it, the photons reverted back to the particle nature. So imagine anything in quantum physics degenerates back to, it is called the quantum discoherence, degenerates back to the particle nature when you start observing it, or when you are not trusting it. So we know about people talking about faith, but faith is truly a quantum phenomenon. And this was how we started approaching the concept of Shiva. And if you look at it, Shiva really means zero. And how it means zero is if you ask in Hindi, Tumhare Shiva without you, Mere Shiva without me, it literally means without. So I understood that the concept of Shiva is actually the concept of being nothing. In space time, you're always stuck between zero and infinity. You can never reach zero or you can never reach infinity, and both are the same. Because if you look at Roger Penrose's cyclical cosmology concept, the universe always starts and ends with space time. So, what is beyond space time? What if somebody moved outside the space time fabric? That is the concept of Shiva, and the ancient Indians knew very well about this. They did not consider this God, they did not consider this something supernatural. And they considered that this was achievable for every human. That's what they call mukti or moksha. And so I started to dwell on it. I started talking to people of science and of philosophy and sadhus. And I started putting my own theory into it, which probably is out of the scope of this webcast. But someday I would love to talk to you about the 7 chakras and how each chakra you transcend and finally you reach Sahasrasara, where you really go out of space time.
Thank you for sharing that. I'm an ardent fan of physics and astronomy. However, my knowledge of spirituality is rather confined. So it was wonderful listening to your theory and your experience about astronomy, space time, spirituality, and of course, let's talk about this some more. And I would encourage you to start your own podcast about topics like this, because this is something that people in medicine, we don't really concentrate too much upon.
We have a channel, Amitabh. We have a channel called Virgo Galactic in YouTube. What we talk about is quantum physics, about the concept of zero and infinity. And this is something very dear to my heart.
Few weeks ago, when we were talking about getting you on the show, you had mentioned about artificial intelligence and visualization paradigms. That is something I know very little about. Would you briefly explain what that is and its relevance for today's neurosurgeons?
If I saw a scan, I could literally reconstruct it, not like something abstract. I can reconstruct a scan in my head and I can project it onto the patient's head. And this way, if I'm doing an aneurysm or if I'm doing a tumor, I'm very well aware of structures that are next to it. This was this was like an eye to me, an extra eye to me. So I try to reconstruct that in neurosurgery, and I call it hypervision. What I did is I took the scan and I reconstructed it in VR and then registered the VR image onto the patient's head. So I realized I could not do it with microscopes because microscopes were, in a geek's language, these are analog images. These are not digital images. So we wanted a camera which could give us digital images. So I started work in 2014. I took 2 universal robots, fixed a webcam and an endoscope to it, and realized that I could make a microscope with these robots. So I wrote a chapter called The Hyperscope in the UNESCO textbook called Digital Anatomy. We did not patent it, but we wrote about it. Escolab picked it up and they made the EOS, the exoscope, one of the first and one of the best exoscopes. And they invited me to their company in Tuttlingen to show me the exoscope. I fell in love with it. I brought it, and today we have one of the largest experience with the exoscope. We were the first in India to get it. We were one of the first in Asia, if not the first. I started working with a company in Chennai. We made our own exoscope, which is called the Sanma Yoko, named after my teacher and my daughter. And then we put hypervision into it. So today, my exoscope, the Sanma Yoko second generation, can have the virtual reality image projected into the surgical field, which we call hypervision. Now we are working on something called Sahasranetra, where the neurophysiology, the navigation is in VR, and I'm using only head mount to, you know, to to see the image. And if I'm pulling a structure, the AI will tell me that this pull will affect the structures behind it in this way. So hypervision, Netra, AI, virtual reality is something that we've been working on a lot and trying to push the envelope.
This sounds straight out of a sci-fi movie. I left neurosurgery more than 10 years ago, and I have not kept in touch with the recent advances. So, all this is very thrilling to me. What the science, what the discipline of neurosurgery is moving towards. And you are a pioneer in this field. Keep up the good work, and we expect more from you.
Thank you. Thank you so much.
Ipe, I remember that when we were in training, you were a fitness enthusiast and you used to do karate. So, do you still do karate?
Yeah, so after I went to Nagoya, I took up mixed martial arts. And so I do a lot of kickboxing these days. So we have a home gym where we do kickboxing, and I do that to keep myself fit. I do quite a lot of trekking, off roading, and kickboxing to keep myself as fit as I can and not pick up any injuries.
The other thing I remember about you is that you had huge vehicles which resembled Transformers. Have you seen those Transformer movies?
Yes, I have.
Yeah, like Optimus Prime and Bumblebee. Do you still have those huge vehicles with you?
Yes, I have a collection of them. I have a monster Jeep with 35-inch tires, completely customized engines. I have a Land Rover Defender, completely customized again. I have another Jeep for routine off-roading. I have a Skoda VRS, which is a drift car. And I have a few other vehicles. I love cars. So I have a S500, a Q7. We have a collection where we are using it for different things. Then I remember my beast from Vellore. It was a Sierra, Tata Sierra.
In contrast, if you see my car, it is the smallest car anywhere it goes. If I drive it into a parking lot, it is not very easy to find it because it will be hidden by the cars around it.
But I remember you had a Thunderbird, and something that I used to love. You had a Thunderbird in Vellore. I remember that.
Yes, yes, I remember that bike too. But after that, I decided to cut down on my gas expenses. So nowadays I buy cars which are really small and compact. The next question is something which I ask all my guests. What legacy do you want to leave for your students and for neurosurgery?
Well, my legacy, I would want to be remembered as the guy who changed a few things instead of going on the beaten track. I wish I would also be the guy who changed things for better rather than for the worse. And that'd be what I would like to be remembered by.
You have proved that you are different. You are not a follower. You don't believe in towing the line. That is why you have been such a trailblazer in the field of neurosurgery. So keep up the good work.
Thank you. Thank you, David.
It was so wonderful talking to you. Time just flew by. It was a real pleasure. Thank you for coming on the show.
It was an honor, David, to be with you. And having been batchmates almost 25 years back, and to catch up now, it was such a pleasure.
The pleasure is mine, Iype. And that's all for today, folks. Thank you for tuning in and subscribe for more.